Hi, everyone, and welcome. Thanks so much for joining us here. My name is Amanda Bassos, and I am the Regional Clinical Outreach Director with Lifeskills South Florida. And for those who might not be as familiar with Lifeskills, allow me a quick moment to introduce our program to you. We are a dually licensed treatment facility where we provide clinical care for adults who present both with complex psychiatric disorders and substance use disorders. And we offer a full continuum of care for now 30 years here in South Florida, from residential treatment through outpatient, which would include our PHP program and our IOP program, and offering transitional housing as an option for many of our clients. Now, we have a robust clinical team made up of doctoral or master's level professionals, all with national training and certifications in the areas of their respective specialties. Now, in order to serve adults with such clinical complexities as we often see, we offer several evidence-based clinical pathways to support the care that we provide. And those pathways include cognitive behavioral therapy, cognitive remediation therapy, trauma, substance use, metabolic fitness, and dialectical behavioral therapy, which we're going to focus a bit more on today. And I'm joined today by Lifeskills South Florida's outpatient therapist, one of our outpatient therapists, Ian Rosenberg, who is a DBT intensively trained clinician through the Linehan Institute. And he's responsible for facilitating the DBT program, DBT pathway for that matter, at our outpatient facility and our male trauma pathway as well at the PHP level of care. And he does tremendous work helping our clients along their journey to continued recovery. So thank you, Ian, so much for joining us today. I'm so grateful for your time.
Oh, of course, I'm happy to help out.
Thanks. Yeah. So, you know, one of the reasons I'm so excited to have you is to learn a bit more about our DBT clinical pathway. This question comes up quite often out in the field from families, individuals, professionals wanting to learn more and understand what it is that we're doing. So to jump right in, can you start by giving us a little bit of an overview on DBT, what it means, what purpose it serves, and what that looks like specifically at our outpatient level of care?
Absolutely. So I'll start with providing the definition of DBT and what it means and the approach and the history of it. So DBT stands for dialectical behavioral therapy, and I'm going to pull a classic and give the definition within the name, or the name within the definition, where dialectical behavioral therapy teaches the client how to look in situations more in a dialectical stance. And what dialects means is that two opposing things can be true at the same time. So the dialects within DBT are acceptance and problem solving, or in change, essentially. So Marsha Linehan, and the genius that she was, she had a long history in behavioral therapy and behavioral psychology. So in the late 1980s, I believe in the 1980s, she was working with a population of highly suicidal females. And she was entering these sessions in a behavioral standpoint. And what behavioral psychology looks at is how can we change our behaviors in terms of reinforcement and conditioning. So when she came into those sessions, the client's response was almost taking a step back and identifying or saying in the perspective that, oh, are you saying that I'm the problem in the situation? And as any person-centered therapist would approach, we're not saying that you are the problem. What we're saying is that there's a pattern of pervasive behaviors that have caused this ineffective lifestyle. So we need to come to the balance of accepting the client unconditionally of who they are as a person, which was more in terms of the validation and the acceptance standpoint. But when Marsha Linehan focused on the acceptance, it was a lack of change. So the clients came into the standpoint and were like, oh, you're not going to be able to help me because we're only reflecting and accepting and validating what they're going through. So Marsha Linehan, in her genius, as I was saying, came to this conclusion that she needed to join those two paradoxes of acceptance and change. So she really found out that problem solving in these situations in a skillful manner allowed the client to change while also balancing the sense of validation and the sense of acceptance. Because we've seen through other remarkable people in the psychology field like Carl Rogers, whose huge contribution to psychology was this idea of unconditional positive regard. And he has this famous quote that says that it's a curious paradox. The moment I accepted myself, I changed. So within DBT, we start to work on allowing the client to accept who they are as a person and accept ultimately the cards that they're dealt and learn how to problem solve around those life situations. So DBT really starts to build its building blocks, if you would, on behavioral science, acceptance principles, and dialectic philosophies. And the merge of those two is where DBT really got its name, in dialectical behavioral therapy. So that's the kind of overview of it.
Yeah, very helpful and very thorough to understand the history, which is really the heart behind its intention of serving and helping individuals not just accept, but also make progress and commitment towards their recovery. Can you describe to us a little bit what that looks like specifically in the PHP level of care?
Yes, absolutely. So originally, DBT was designed for an outpatient setting. So what that means is coming into treatment while living in their natural environment. So natural environment in this perspective is allowing the client to be submerged or immersed in what they would actually experience on the outside. Because at the residential level of care, we are really trying to address the life-threatening behaviors that the client is engaging in and the emotional vulnerability. So DBT really divides its treatment targets into 4 different stages, where the first 2 stages of DBT are really to decrease that emotional vulnerability while also decreasing that life interfering behavior. So that's where we're going to work with the client to reduce the substance use behaviors, because unfortunately what we know now with the opioid epidemic and fentanyl, that there is a lot of counterfeit medication that is going around that's laced with fentanyl. So where it used to just be this substance use disorder that ultimately people would be able to live with substance use disorder for a long time. But now with the introduction of fentanyl and all the analogs of fentanyl, that it's really hit or miss with where they're getting their drugs, the quality of them, and the practicality of whether or not they're going to live or die. Because it's shot in the dark, unfortunately, in this day and age with prescription medication and narcotics that we have. So at the residential level, we reach to decrease those behaviors to allow the client to get to a stage that then allows them to come to the outpatient level. And the outpatient level really is able to pick up the baton and run with it because they are that much closer to their natural environment. So at PHP, we are going to strongly recommend them to enroll in a class in school or apply for jobs or anything community service, anything that's going to be outside extracurricular activities, because then we fully get to see how that client interacts with their natural environment and the different targets that come up. So the stage 3 targets are really problems in living. And what we can kind of go and take a leap on and say that if somebody throughout their entire life has never been able to hold down a job, is unable to hold down relationships, or is unable to excel in school and repeatedly has to withdraw, where is their sense of self? Where is their sense of self-confidence and self-esteem? That if we're checking the facts, they have complete rights to feel that down upon themselves because they haven't been able to really experience life for all of the quality that it can provide us. So at this level, we're able to support the client to go through these different stages while supporting them in the sense of validation and understanding how hard it actually is to go through 10 different interviews, hear back from half of them, and the half that we hear back from is saying, oh no, we're not hiring right now. That's extremely defeating. So we get to sit in that session with the client and validate that heartache or the difficulty that they have interacting with it, while also teaching them how to rebound that much quicker in the situation to allow them to be more effective. So at this level, we strongly encourage to go through these processes, to have different treatment targets. Even if they are somebody who's out of state, we're going to strongly encourage them to go through different interview processes, because they're going to have to experience this once they go back home. So within our format, and this is really where Lifeskills really is able to highlight its effectiveness, is that the step down process within itself is some form of exposure. So when they get to this PHP, they're exposed to the different types of ins and outs that we would have to navigate on our own without treatment. So we get to increase their idea of self-respect, their idea of self-esteem, and their sense of morality and their mastery, and that they feel that sense of accomplishment and say, hey, you know what? I can actually do this. And then once that spark hits, we run with it and really take hold and reinforce it through the behavioral mechanism that DBT still comprises itself of, to reinforce these positive changes.
Wow, Ian, so thorough. Thank you for that.
No problem.
Very clear picture. You know, I think you've hit on a few different things. One is just the intentionality of the continuum of care. You know, we say that word, but we truly do mean that, from residential all the way through. It's not just basic DBT. We are incorporating life skills, which is our name, of course, but life skills into the curriculum that is DBT, into the meat and potatoes, if we can say that, of DBT, to put the skills and allow the skills to come into practice, into everyday experiences that our clients will have when they're outside of therapy.
Yep.
And so helpful for them to experience the successes and the trials that come in a safe and supportive environment, which is with you in therapy or within their group. So thank you for that descriptor. Now, I know that a part of DBT, a huge part of DBT, is mindfulness. Now, as a human first myself, I understand that practicing mindfulness is so much easier said than done sometimes, but it's still a value. Yeah, of course, that's fair. Can you tell us a bit about, you know, mindfulness and just the benefits that come with prioritizing?
Yeah, so mindfulness really at DBT's core is the main motivating force behind how we should view life and our perspectives in life. So mindfulness is the core skill of DBT. So we should always have that perspective or that lens on within mindfulness. So then I'll also provide a definition of mindfulness. We have to also respect mindfulness in that there's hundreds of different definitions of mindfulness. And that mindfulness is really, if we want to think about it, one of the oldest therapies that we actually have, because it dates to the far east and to probably BC era of human life, of Zen practices and mindfulness. So Marsha Linehan really was able to identify those practices and how it helped her, and she built DBT around those mindfulness practices. So the definition of mindfulness, or one definition that we can think of mindfulness, at least in a psychological standpoint, is the deliberate act of paying attention to the present moment without judgment. Because we also have to think about what kind of makes us human in a ineffective way or maladaptive, depending, unhealthy, so many different types of jargon that we can apply to it, is that our brain works on patterns. It likes patterns. It likes to fill in the blanks. It doesn't like guesswork. So when we think about mindfulness in DBT, we also have to respect the idea that the original population that DBT was made for was the borderline personality population. And a composition of that, or a statistic within borderline personality disorder, is that over 85% of individuals diagnosed with borderline personality disorder will have some form of trauma in their lifetime. And another way of saying trauma is adverse life events, but to the extreme and diagnostic level, we can say PTSD. And for some professionals, they would fall PTSD under a way of saying a memory disorder. because the way that our body and our mind remembers these traumatic events teaches our mind to generalize this experience to the vast majority. So what that means is that I'm going to generalize my traumatic experience across different contexts that I find myself in, even though I am nothing close to my past experiences, the age that I was in, the situation that I was in, or the environment. That all of these things are different, but there are going to be these slight little cues that pop up in my environment that then causes the alarm bells to pop off. So within mindfulness, what we've been able to find within research and study, that the emotional vulnerability part in multiple disorders, borderline personality disorder, anxiety disorders, and depression, that these are relatively biological vulnerabilities that some can be intervened with pharmacological intervention. And at the same time, there's still going to be a pervasive pattern because of these gradual experiences and repeated experiences too, because there's also complex trauma and repeated traumas that we're working with within PTSD and borderline personality disorder. So within the practices of mindfulness, we've been able to see at a neurological level the impact that mindfulness has. Because the way that our brain is made up, that if we're thinking about the connection between the different parts of the brain, the amygdala and the frontal cortex have a strong connection with each other. And if we look at the structure of the brain, they're relatively overlapping with each other. So the ability for the brain to go from the amygdala to the frontal cortex is almost a direct shoot. And what that translates to is that our judgment of a situation is going to directly send off these warning signals. So I can be in a classroom and I can hear how one person is communicating. And that style of communication reminds me of my rearing environment or the environment that I grew up in. And it causes me to start to have a panic attack or anxiety or avoidance behavior, shut down, or even to the extreme dissociation. Because we have these phenomenon in memory called flashbulb memories. So one of the ways that I like to describe it is that for individuals with trauma, PTSD, and borderline personality disorder, that the combination of all of them is the inability to regulate our emotions with also the inability to discern the differences of safety and anxiety. And then if we're thinking about this flashbulb memory idea, is that we are literally expecting a student to excel the same as everybody else sitting in the classroom in front of a strobe light when all the other students don't have a strobe light in front of them. So that's why we see so much avoidant behavior, so much lashing out behavior, because they're trying to figure out how to regulate this emotion. So mindfulness, what it does is to really try to change the neuroplasticity or that's what we've seen through brain scans and studies, that mindfulness allows to change the structure of the brain through this mechanism called cortical thickening. And what cortical thickening is the stronger, or the more that we use it, the stronger it gets. So mindfulness, if we're able to take this non-judgmental perspective, that we're accessing one part of the brain, which is required or important for sensory information. So it's the intake of sensory information. So the more that we can solely access this part of the brain while also utilizing DBT perspectives in the observe and describe, aka the mindfulness skills of what and how, we're able to observe, describe in a non-judgmental way what is actually going on in the environment. And then once we're able to mindfully take this assessment of what the environment is telling us, we can then start to have these building blocks for other DBT skills, like check the facts. Am I actually in a threatening environment? What is the likelihood of this being a catastrophe? What is the threat that I'm experiencing right now? So through mindfulness skills, we're literally able to make a path in the brain to delay that immediate reaction that the amygdala would send off and to fire off, which would then cause for ineffective or maladaptive behavior. So really self-harm is one way that maladaptively people have been able to reduce their symptoms, because we know about self-harm, it's very known and talked about. And the downside is that self-harm works. It actually works. We've been able to see that it does reduce neural activity in the brain after somebody engages in self-harm. What we don't take into account is all the secondary emotions associated with that self-harm, or the fact that self-harm did not actually solve the problem. It solved the emotional experience, but it did not solve what caused the problem. So that's, again, the importance of the different stages in DBT to address that. So mindfulness is able to reduce the suffering because it allows us to take the suffering out of the equation, because suffering comes from the judgment of it. So we're also able to increase the control of our mind by deliberately paying attention. So if we can increase the control of our mind and what we pay attention to, we're also able to decrease the impulsive behaviors that people can engage in too. So with mindfulness, we try to take this impartial viewer perspective of our own experience. What would a third person think about, view, see, and feel in this situation that isn't bringing my experiences to the table? Is everybody going to think that this person is condescending or invalidating? And at a certain point, we check the facts and be like, oh, no, this is my experience. And then that's where we go into the validation. Yeah, there's a very good reason why you're having this startle reaction. You're a survivor. You're a survivor of trauma. Right. And then at the same time, yes, you are a survivor in trauma, and that's horrible. So let's figure out how we can change that. So that's where the problem solving and the change idea in DBT comes in, is we have to accept and then change the client, or change the pattern or the behavior and the skillful means that the client has to access to increase the likelihood of a good prognosis.
Ian, that was so, again, comprehensive and very thorough. It's clear that mindfulness is such a solid baseboard of where to start in terms of, building skills off of the practice of mindfulness, and to move forward on whatever that journey is for the individual. And I love how it's prioritized, not just within DBT, certainly we just spoke of that, and also how that's translated and reflected at Lifeskills as a value. One example is providing yoga throughout the week for our clients, because we know yoga has so much foundation within mindfulness. And I know that you have the reputation around Lifeskills for hosting so many of your groups with time for mindfulness at the beginning, middle, or end, in order to just keep integrating those skills that you spoke of. And practice helps. We know this. So great way to model that effective care. One last question. I'm curious why you think that Lifeskills is so effective in the clinical care that we provide. What are your thoughts on that?
Loaded question. The honest answer, what I think Lifeskills really takes pride in within itself internally, is allowing the therapist to practice what they're passionate about. Because obviously we are all trained and all experts in therapy overall, and we can do a wide range of eclectic approaches. But what Lifeskills really does is to have these specific tracks or these specific expertise that are some of the strongest evidence-based practices in the field that we have, and allow those people to really practice what they're passionate about. Because especially with DBT, that it's a combination of both the effectiveness of the therapy and the clinician, that you can have a client come to a great DBT therapist who knows it through and through, but if there's no connection or there's no personal ties with it, it's not going to necessarily stick. So by allowing clinicians to really practice what they're passionate about, it gives off the signal, it gives off the aura, the vibe, depending on how we want to talk about it, of this works, and that there is a level of commitment that if you commit yourself to this, that it will change your life in a positive way. So it works on the passions of the therapist and allows them to practice what they're passionate about. And then also the fact that we offer the full continuum of care all the way from residential to outpatient, where I firmly believe in the step-down process, because also within DBT that there is an exposure variable in this. And that's ultimately what I was saying before, that the step-down process is to continually expose ourselves to lesser structure and more natural environment. So where we go from 24-hour care to about 32 plus hours at the PHP level to 9 hours at IOP to outpatient, these are stark differences in time. And what we also have to respect is how we ended up in Lifeskills in the first place. One of the precipitating and perpetuating factors was the lack of structure or the lack of commitment. So with our structure in place, that we're able to gradually expose that client to their natural environment where it's not night and day. So even if we do, let's say, step them down to outpatient, the step down process is done internally, so it allows for really a heartfelt, warm handoff to the other clinician. That obviously we have our best practices, all treatment facilities has their best practices in sending collateral information during a transfer, absolutely. But what we miss is that heartfelt sense connection when we send paperwork. It's paperwork at the end of the day. You don't get the feel of the client. You don't get to see what actually worked out in the therapeutic process from both the clinician and the therapist within a 1 hour process or a 1 hour interaction. So every morning at Lifeskills, we have a morning meeting that all different levels at Lifeskills come together and we're able to do this warm handoff. So even if I'm not necessarily getting one of these clients in 60 days, I at least get to hear 60 days worth of updates of this client, be like, all right, that's the personality aspect of them. That's a behavior aspect of them. That's about them. So I'm getting to paint a picture of their day-to-day functioning rather than seeing a quick vignette of who they are and what they're about. So I think it's really the heartfelt sense of the step down process and the care that we take, the deliberate care and intention that we take in allowing our clinicians to get trainings and practice what they're actually passionate about. Just like what Lifeskills was able to do for me when I first started in the field too, because I've started with Lifeskills and really started here for their DBT track. And thankfully they kept me around and now I'm doing DBT at the outpatient level.
Well, yeah. Yeah, it's very clear why, because you are so well trained and so passionate, to echo your word, about the work that you provide. And I know that that is equally echoed with each of our clinicians, every member of our staff. There is that level of passion that is incredibly beneficial to the therapeutic experience, because there is connection that comes through that. People do feel that. And with that, there's the opportunity to build on safety for the client, and safety in the support of the therapeutic relationship, because you're just as passionate to be there to help them.
Yep.
And that is evidenced in hearing you speak today. And I also want to touch on exactly what you said, that at Lifeskills we do prioritize the multidisciplinary approach to treatment, in that our team comes together every day. And there's a consultation and there's care that's provided for our clients. So, and that continues, not just at the end of discharge from residential, but that will continue through each level of care, so that there is, in fact, continuity of care, because that is so important to us. So thank you so much for your time, Ian, and for all that you do every single day for every one of our clients at the PHP level of care. You know, I know, because I have heard and I have witnessed how great it is to be a member of one of your groups and to work with you. So keep doing the great work that you're doing.
Glad.
And thank you for the time and energy of sharing with us today so much detail on DBT and on mindfulness specifically. So for those watching, if you have any additional questions about Lifeskills South Florida, about our PHP level of care, about our DBT program, or about mindfulness, feel free to reach out to myself, to Ian, to any member from our team. We are more than happy to answer any and all questions that you might have. So thank you for joining, and we hope to see you again next time. Thank you. Take care.
Bye.